Hi, so today our topic is going to be on immunodeficiencies, and it's one of the most highest yield topics. So first of all, a brief overview. So I have divided them into categories. The first one is going to be their B cell or humoral deficiencies, right? So these are going to be deficiencies in which you are going to see recurrent bacterial infections, right? Because your antibodies are responsible for clearing out extracellular bacteria. Next, you will have the T cell or cellular immunity deficiencies, right? So T cells are responsible for your cellular or cell mediated immunity, and you know that that is particularly effective against viral or fungal infections, right? So intracellular infections. Next, you have B plus T cell deficiency. So your B and T cells are going to be deficient, and obviously you will be infected with bacterial infections, viral and fungal, so all of them, right? And they are very severe. And finally, you have innate immunity defects. So your innate immunity defects are going to be defects in neutrophils and macrophages, right? And one high yield point that I want to tell you is that immunodeficiencies are often associated with an increased risk of autoimmune diseases and malignancies, right? So immunodeficiencies, autoimmune diseases, and malignancies, they are all associated with each other, okay? All right, so first, the B cell deficiencies. So the first one that we have is going to be Bruton's A gamma globulinemia. So the way that you can remember this is a B cell deficiency is that the B in Bruton stands for B cells. And it is also known as X-linked A gamma globulinemia. So it's an X-linked recessive mutation in Bruton tyrosine kinase, right? So X-linked recessive meaning it is going to be more common in boys, right? And it's a mutation in Bruton tyrosine kinase. BTK is responsible for B cell maturation. So obviously, if you have a mutation in BTK, you will have a failure of B cell maturation. So that is why you have low B cells, right? So you don't have mature B cells. You will obviously then will not have low plasma cells, right? And because your plasma cells are low, you will have low immunoglobulins or antibody production. And another point that you have to know is that your lymph nodes, right? Your lymph nodes predominantly consist of B cells, especially the follicles and the germinal centers, right? So it makes sense that if you don't have B cells, right, so your lymph nodes will be absent or scanty, right, meaning low in amount. And it is usually onset is after 6 months because the mother's antibodies will protect the baby for 6 months, but after that the baby has to make their own antibodies, and when they cannot make their own antibodies, obviously they will be more prone to bacterial infections. So recurrent bacterial infections which will be seen due to impaired humoral immunity. Why? Because you cannot make your own antibodies, right? And some special organisms that you have to know about, especially encapsulated organisms such as strep pneumo, pseudomonas, haemophilus influenza, right? And you may also get infections due by Giardia, right, due to low IgA. So on flow cytometry, right, you will see low CD19 positive B cells. So CD19 is basically a marker for B cells, CD19 and CD20. So obviously, if you don't have B cells, you'll have low CD19 and 20. And plus, all your immunoglobulins levels will be very low, right? And when you take a biopsy, it will show absent follicles and germinal centers because your lymph nodes are mainly consistent of your B cells, right? And finally, you avoid live vaccines because live vaccines can go active in these patients and they can infect the patient. And along with that, you give IVIG replacement, right? Because these guys cannot make their own immunoglobulins. So obviously, we have to give them antibodies. Next, we have selective IgA deficiency, right? It is one of the most common immunodeficiencies that is seen, and the onset is mostly in adolescents, like teenagers or adults, right? So not in infancy. So basically, there's a defect in the B cells to class switch to IgA, right? So that's why you have low levels of IgA, and you know that IgA is responsible for your mucosal defense, right? So your respiratory tract, your GI tract, your genitourinary tracts, right? So they will be prone to infections. But all the other immunoglobulins levels, they will be normal. So how does this present normally? So recurrent sinopulmonary infection. So your sinuses and your lungs or your respiratory tract, they will be most commonly affected, right? And they will be mostly affected with bacterial infections. Another high yield point that you have to know is that you're also prone to recurrent Giardia lamblia infections. Okay, so Giardia lamblia is basically a motile protozoan, right? So it's a motile protozoan that is mostly responsible for what is known as steatorrhea. So steatorrhea is basically fatty stools, right? And the way they are usually described is foul, smelly, floating stools. And what happens is that basically your GI tract cannot absorb fats. And you know that some of your vitamins are fat soluble, such as vitamin A, D, E, and K. So maybe in the question they can also present like a vitamin deficiency, basically pointing towards the fact that there is no absorption of fat, right? And Giardia infection is mostly seen in people who mostly go for camping, right? And it is transmitted through a oral fecal route, right? So people who go to camping and maybe they ingest dirty water, right? Or people who go for hiking, right? So mostly in those scenarios. And there's also an increased association with atopy. Atopy basically means any allergic reaction such as asthma, eczema, allergic rhinitis, right? That is also seen. And there's also an increased association of developing an autoimmune disease, right? And the most important example is going to be celiac disease. I will talk about this in a second. But you also have an increased association of developing SLE, rheumatoid arthritis, right? Stuff like that. But celiac disease is the most important one. And it is usually detected in adults with basically who have recurrent infections or who have a family history or they have a history themselves of an autoimmune disorder. So two special associations that you should know, that these patients can develop anaphylaxis after transfusion of blood. And I've talked about this in my previous lecture. What basically happens is that these patients develop what is known as anti-IgE antibodies, right? And it's because of these antibodies that they are targeted against the donor's IgA. So if the donor's blood contains IgA, that can lead to an anaphylactic reaction in these patients. Plus, they also have celiac disease association. So celiac disease is basically an autoimmune reaction or a autoimmune disorder against gliadin, which is a component of gluten, right? And they develop these IgA antibodies, which are named as anti-tissue transglutaminase, right? Anti-endomysial antibodies or anti-gliadin antibodies. So these are basically markers, right? And the one important point that you have to know, apart from these antibodies, is that these antibodies can cause destruction of the intestinal wall, right? Especially the intestinal villi. So if you look at an intestinal wall, right? So let's say this is an intestine, right? So you have these villi. These villi are important for absorption. So in celiac disease, these villi, they are literally destroyed. So it's like you have shaved off these villi, right? And I'll show you an image of what it looks like. But this is known as villous atrophy, and this can lead to malabsorption, and that can present with, just like I said before, steatorrhea, bloating, and a very important test which is known as D-xylose test, right? So D-xylose test is basically responsible for checking, is the intestinal wall intact? If it is abnormal, right, that means the intestinal wall is damaged due to some reason. And obviously, since you have villous atrophy in celiac disease, the D-xylose test will be abnormal. But in another conditions such as lactose intolerance, the D-xylose test will be normal, right? So just a little high yield facts, okay? And another thing that you have to know is that these patients are very prone to developing iron deficiency anemia, right? So celiac disease patients can develop iron deficiency anemia, a very high yield point. And the final point that you have to know, that these patients who are IgA deficient, who have developed celiac disease, they can have a false negative celiac serology, meaning that because their IgA antibodies are so low in levels, right, those antibodies that I just named, right, which are basically anti-tissue transglutaminase, anti-endomysial, anti-gliadin antibodies, and those are IgA based, right? So if your IgA antibodies themselves are very low in amount, you cannot detect these antibodies that I just named, right? And sometimes these result in a false negative test, right? False negative test meaning that in reality, the patient has the disease, but the test showed that the patient does not have the disease. Okay, so that's known as false negative, right? All right. So first, this is an image of Giardia lamblia. So it's a motile protozoan, right? And this is the trophozoite form. So this is the trophozoite form. And you can see it has these flagella, right? They are important for its motility, and it's binuclear. So these two nucleuses are also there. So just remember this image, because a lot of the times they directly give you this image and they ask for this microbe specifically, and especially also the treatment. So I'm just very randomly saying the treatment for Giardia is always going to be metronidazole, a very high yield drug, by the way. Okay, so metronidazole. And this is the image of villous atrophy. So if you have seen a normal intestinal wall histology, you have seen that it looks like this. Okay, so there are these intestinal villi. So one of the most funny ways that I remember, I think of these villi as like someone's hair, right? And what happens in villous atrophy, you literally take a machine and you shave off all of the villi. So it looks like that these guys are bald, right? So that's one of the most funniest ways I remember celiac disease. So you can see that there are no villi, and because of that, that leads to malabsorption and the other symptoms that I just talked about. And obviously, since you have steatorrhea, you will be also deficient in fat-soluble vitamins. Next is a CVID, or common variable immunodeficiency. I think of it as a less severe form of Bruton's, right? So over here you have a normal B cell count, but the B cell maturation is still defective. So again, you will not have plasma cells and you will have low amounts of antibodies, right? But the important point is that it presents later in life, unlike Bruton's, which presents in infancy. Okay, and the symptoms will be same, just recurrent bacterial infections. All right, now for the T cell disorders. So first is Dijort syndrome. Dijort syndrome is a 22q11 microdeletion, right? So a 22q11 microdeletion, and that leads to failure of development of third and fourth pharyngeal pouches. So you know that there are clefts, arches, and pouches. Clefts are ectodermal, arches are mesodermal, and pouches are endodermal. So this is an endodermal development disorder. So the third pouch makes your thymus and inferior parathyroid, and the fourth pouch makes your superior parathyroid, right? So the one way that you can remember the parathyroids is that third makes your inferior and the fourth makes your superior. So it's just inverted, right? Now it makes sense that since you don't develop your thymus, and thymus is literally responsible for your T cells, so if you don't develop your thymus, then obviously you will have no T cells and you will be more prone to recurrent viral and fungal infections, right? And your parathyroids are going to be responsible for regulating your calcium levels, especially increasing calcium levels in the blood. So parathyroid releases a hormone that is known as parathyroid hormone. Parathyroid hormone is responsible for increasing calcium in the blood and maintaining calcium levels, right? So again, if you don't have parathyroid hormone, then obviously your calcium levels will be low. That can lead to hypocalcemia. And this is one of the examples of primary hypoparathyroidism, because there's something wrong with the parathyroid gland itself, right? And hypocalcemia obviously presents with some signs that are high yield, that is known as like Chuvetsky's sign. Chuvetsky's sign is when you palpate their their masseter muscle on their cheek, then that can lead to a sudden contraction on that side. So that is known as Chuvetsky's sign. And that can and another sign that you have to know is known as Trousseau's sign. So in Trousseau's sign, basically what happens is when you take their blood pressure and when you bind that cuff on their arm, right? So what happens is that binding of that cuff will lead to the carpopedal spasm, right? So their hand starts to spasm. And remember one thing, that in hypocalcemia patients, we always see what are known as tetany, right? So stiff muscles, right? And seizures. So these are one of the common signs of hypocalcemia. Okay, so other clinical features that you see are cardiac abnormalities such as STOF, which is tetralogy of Fallot, and truncus arteriosus. So tetralogy of Fallot, obviously the four things that you have to remember are going to be pulmonic stenosis, right? Overriding of aorta, right ventricular hypertrophy, and obviously VSD, right? And TOF is due to abnormal placement of the infundibular septum. Truncus arteriosus is when you have a single outflow tract, right? So a single outflow tract, that is truncus arteriosus, and this is due to failure of neural crest cell migration. And both of these disorders are very dangerous for an infant, right? And then you also have abnormal facial structures, right? So abnormal facial structures are going to be like, cleft palate, or basically abnormal facial bones, right? And you also have thymic aplasia, basically meaning that you will not have a thymus. And again, if you don't have a thymus, you don't have T cells. And if you don't have T cells, then you will be more prone to viral and fungal infections. And the microdeletion is detected through a process that is known as FISH. FISH is fluorescence in situ hybridization. FISH is used to detect microdeletions. The reason being because karyotyping cannot detect your microdeletions, right? So FISH is a process that is used to detect these microdeletions. And finally, obviously, I've talked about this before in the thymus lecture, that you will have an absent thymic shadow on chest X-ray in neonates. Next is interleukin 12 receptor deficiency. And this is going to be an autosomal recessive defect in interleukin 12 receptor. I've talked about interleukin 12 before, but just for a recap, interleukin 12 is released by macrophages, right? And then it induces T helper 1 differentiation. Do you remember what's the purpose of T helper 1? Yes, T helper 1 is responsible for cell-mediated immunity, right? So cell-mediated. And then the T helper 1 cell releases what is known as interferon gamma. Interferon gamma acts on the macrophages and it leads to granuloma formation, which is basically a collection of epithelioid macrophages and histiocytes, right? So obviously, if you have an interleukin 12 receptor deficiency, then your interleukin 12 will not be able to perform its functions, and you have defective cell-mediated immunity. This can lead to disseminated mycobacterial and fungal infections, right? So you have to know that granuloma formation is done by especially two infections, which is mycobacterial. And in mycobacterial, the most important example is going to be tuberculosis, right, or TB, and also fungal infection. So these are two that you observe, that you really have to remember, right? Now, you also avoid the BCG vaccine, because the BCG vaccine is given for Mycobacterium species, right? Now, what is the most classical presentation? Recurrent TB infection since childhood. So normally in childhood, you don't see TB infections. It's not something that is really common. It is usually seen in adults, right? But recurrent TB infections till childhood, they occur in interleukin 12 receptor deficiency. The reason being because you know that granulomas are important for preventing the disseminated TB infection. And by disseminated, I mean the systemic TB infection. So that's going to be like Pott's disease. So Pott's disease is basically destruction of the vertebral bodies by TB. You can also get tuberculous meningitis, right? So these are very dangerous complications, or basically disseminated. These are consequences of disseminated TB infection, right? And in the labs, right? So in the labs, you will see low interferon gamma, and the biopsy will show no granulomas, right? So you cannot form granulomas because, again, granulomas are important for containing TB infections, right? So this is what a granuloma looks like, and I want you to burn this image in your mind. So this is basically a granuloma, and it is mostly seen in chronic inflammations, right? So these are the collections of the epithelioid histiocytes and macrophages that are inside, and there are also giant cells present, right? So this is what a granuloma looks like. Next, chronic mucocutaneous candidiasis. Chronic mucocutaneous candidiasis is one of the presentations of autoimmune polyendocrine syndrome, right? Which is due to AIR gene mutation. AIR gene, I've told you before, is responsible for negative selection in the thymus. So if you have a mutation in AIR gene, then obviously you have loss of negative selection. And if you have loss of negative selection in the thymus, you have defective or dysfunctional T cells. And when you have dysfunctional T cells, then obviously you will be more prone to fungal infections, and especially in this case, candidal infections. I've talked about candida before. It presents like an oral thrush that can be scraped off with a tongue scraper, right? And there will be absent type 4 hypersensitivity reaction against candida antigen. So I've talked about type 4 hypersensitivity in my previous lecture. So type 4 hypersensitivity is going to be testing your T cells. So if there is a type 4 hypersensitivity reaction, which is basically an induration, if you see that induration, that means your T cells are working. But if you don't see that induration, that means your type 4 hypersensitivity is not working and your T cells are dysfunctional, right? And there are other endocrinopathies also present, such as adrenal insufficiency. All right, next we have autosomal dominant hyper IgE syndrome, that is also known as Job syndrome. So in this disorder, we have what is known as a STAT3 mutation. STAT3 is an important gene that is present in T helper 17 cells. The main function of T helper 17 is basically recruitment of neutrophils to the site of infection, right? So T helper 17 cells have this important function. Now, makes sense that if you have a mutation in STAT3, you have dysfunctional T helper 17, and if you have low T helper 17 cells, that means that you have impaired recruitment of neutrophils to the site of infection. And that is one of the reasons why we see cold staphylococcal abscesses. This is one of the most highest yield finding in this disorder. Why the cold? It's because if you don't have neutrophils in abscesses, then you have a lack of inflammation despite the infection, right? So and you know that Staph aureus is one of the most common causes of abscesses. So let's say that, and you know that abscesses are obviously basically a way of body to wall off an infection. So over here you have Staph aureus, right? And this is an abscesses where they're walled off the infection. Normally the neutrophils will enter and there will be like a fight. There will be a fight between the microbes and neutrophils and whatnot. And now the problem over here is that you don't even get your neutrophils inside. So obviously you will have a cold staphylococcal abscess, right? Another thing that you will see is retained primary teeth, right? So there's a failure of shedding of the baby teeth. So you will see what is known as double rows of teeth. Other dermatologic findings are seen, such as pruritic skin lesions and eczema, right? And there's also weak bones that can lead to pathologic fractures. And obviously the name suggests hyper IgE, so obviously you will get increased IgE levels, and I've already told you that IgE is associated with eosinophils, right? So the E and eosinophils, so obviously you'll have increased eosinophil levels in this disorder also. Next, now we're going to talk about the combined B and T cell deficiencies. So the first one and the most highest yield one is going to be SCID, severe combined immunodeficiency. There are three disorders that there are three causes of it that you have to know. So the first one and the most common one is known as interleukin 2 receptor gamma chain mutation. It is X-linked and it's the most common. X-linked, again, more common in boys. So interleukin 2, again, I've talked about this before, is an important cytokine that is responsible for the T cell maturation and the T cell activation. If you cannot activate your T cells, then the B cells, they don't get activated either. So you have a combined deficiency of both, right? Next, ADA deficiency. So adenosine deaminase deficiency. This one will be autosomal recessive, right? So it can also be seen in girls. So ADA deficiency, right? Normally adenosine deaminase, it converts adenosine, right, into inosine. And then inosine is then degraded. Now what problem happens is that since your adenosine deaminase is dysfunctional, you get increased buildup of adenosine, and then that adenosine is phosphorylated. So phosphate groups are added, and that leads to accumulation of DATP, right? So this excess DATP, it is highly toxic to lymphocytes, right? Why? Because increased DATP levels inhibit the enzyme that is known as ribonucleotide reductase. And you know that ribonucleotide reductase is a very important enzyme that is responsible for DNA synthesis. The final cause is RAG1 and RAG2 mutations. I've mentioned these enzymes before. So RAG1 and RAG2 are responsible for VDJ recombination. So obviously VDJ recombination is a process that is important in antigen receptor formation, right, in B and T cells both. So again, if you don't have your RAG1 and RAG2, you cannot make your T cell and B cell receptors. And if you cannot make them, then overall you do not even have your adaptive immunity with you, right? So that's another important point. Now, although all of these causes lead to B and T cell deficiency, right, the presentation will be the same. So you have low B cells and T cells, and you have increased risk against all types of infections, right? Viral, bacterial, fungal, protozoal, all types. And the onset occurs in infancy, right? Just after 6 months. And it occurs with a failure to thrive because since they have such a very severe susceptibility to infections, they have a very low chance of surviving. And because you don't have T cells, so you won't get a thymic shadow, right? And because you don't have B cells, then you won't get your lymph nodes, and you'll have low amounts of immunoglobulins. So both of them will be absent. And the flow cytometry will show low CD3. CD3 is a marker of T cells, right? And you will have low CD19 and CD20. So these are markers for your B cells. And finally, for treatment, obviously you will do a bone marrow transplant and you avoid live vaccines. All right, next we have ataxia telangiectasia, right? It is due to ATM gene defect, right? And ATM means ataxia telangiectasia mutated. Surprise. Anyways, this is due to a defect in non-homologous end joining. Non-homologous end joining is one of the processes of DNA repair, right? So the normal function of ATM gene is to detect the DNA double strand breaks that happen due to multiple reasons, like let's say radiations, right? So it is to detect those breaks and activate P53. P53, I will talk about this later on, but it basically controls your cell cycle, right? So it tells P53 that, hey, we have some mutations, we have to correct them before moving forward, right? So P53 says, okay, let me hold on the cell cycle and let me check, right? And then that allows for the DNA repair, which is known as non-homologous end joining. Now, obviously, if you have a defect in ATM, you will have a defect in non-homologous end joining. Now what happens is that this leads to some symptoms, right? So first of all, ataxia. Ataxia is due to the cerebellar atrophy, right? And it also leads to telangiectasia. So telangiectasia are going to be tortuous or dilated and basically tangled blood vessels that you can see on the patient, right? And I'll show you an image of what it looks like. And you also have an acute increased risk of cancer because you know cancers are due to mutations in the DNA, and if you cannot repair your mutations or if you cannot correct them, then you obviously will have an increased risk of cancer, right? Especially of lymphoma and leukemias. And again, they will be very sensitive to radiations because again, radiations, they are responsible for breaking down your DNA, right? So, and if you cannot correct them, then obviously that can lead to mutations. And the labs will show a decreased IgA, IgG, and IgE, right? And this specific disorder is very special because it is the only disorder in which you see increased AFP or alpha fetoprotein. So this is what telangiectasia looks like. So you can see it kind of looks like a spider, right? So all of these blood vessels are like tangled with each other, right? And it kind of looks like what is known as a spider angioma, right? So this is what is known as telangiectasia. You can see how torturous they are. Next is hyper IgM syndrome, right? I've talked about this before. This is an X-linked defect in CD40 ligand on the T cell. So I've talked about this before. There are two signals, the primary signal and the secondary signal. The primary signal is going to be between between MHC2 and the T cell receptor, right? So this is the first primary signal, and then you need a secondary signal to activate the B cells, which is going to be between CD40 and CD40L. So obviously if you have a defect in CD40L, you will not have the secondary signal, and that can lead to no class switching, right? And can you remember the interleukins that are responsible for class switching? Exactly. So you will have low levels of interleukin 4 and 5, right? So they will also be low. So what will the labs show? Obviously the name is hyper IgM, so your IgM levels will be high or normal, but your other immunoglobulins levels will all be low, IgG, A and E. And again, you know that class switching occurs in the germinal centers in the lymph node. So obviously if there is no class switching, there will be no germinal centers present in hyper IgM syndrome, but the B cell count will be normal because there's nothing wrong with the B cell maturation, right, or growth. And again, there will be recurrent bacterial and opportunistic infections. All right, next we have Wiskott-Aldrich syndrome, right? I hope I'm pronouncing that right. This is due to an X-linked recessive defect in the WOS gene, right? So the WOS gene is responsible for cytoskeletal reorganization, right? So the cytoskeletal reorganization. So what you have to know is that the T cells, they cannot properly reorganize their actin cytoskeleton. So the point that I'm trying to make is that the cytoskeleton is important for the interaction of the T cells with the antigen presenting cells. So if you have a defect in that, then obviously you'll have a problem with interaction with the antigen presenting cells. And if you have a problem with interaction with antigen presenting cells, then obviously you'll have an impaired antigen presentation. And obviously you know that antigen presentation is very important for the B and T cell function. So this is why we have a combined B and T cell deficiency or dysfunction, and it is presented with a triad of thrombocytopenia, meaning low platelets. So you will see stuff like petechia, right, or maybe some ecchymosis, right, on the skin, and eczema and recurrent infections. Plus, in this particular disorder, you will have increased IgA and IgE levels, and your IgG or IgM will be either decreased or normal, right? And there will be increased risk of developing autoimmune diseases and malignancies, right, especially lymphoma and leukemia. And one of the most interesting ways that I remember this specific disorder, because it kind of gets really confusing, I remember it by water. So remember it like this: WNA stands for Wiskott-Aldrich, right? And the TER represents your triad, which is thrombocytopenia, eczema, and recurrent infections. And one more point, you know that IgA and IgE are the only ones that are high, and water contains A and E. So these are the only ones that are going to be increased in levels. So IgA and IgE. So this is a very easy way to remember the whole disorder. So just remember water. All right, now we are going to be talking about the innate immunity defects, right? So defects with the neutrophils and macrophages. So the first disorder, which is high yield, is known as leukocyte adhesion deficiency. This is going to be an autosomal recessive disorder in LFA1 integrin, right, which is also known as CD18. Now let me tell you what an integrin is. Integrin is basically a molecule that helps in the neutrophil to adhere to the endothelium to basically help it with migration to the infectious sites. So this is a blood vessel, right? Obviously this is the tissue, right, where the infection is going on, where the microbe is present, and the neutrophils are traveling in your blood. So obviously your neutrophils have to travel in the blood and then get to this site. In order to get to this site, they have to undergo a whole neutrophil extravasation process, right? And that has a lot of steps, which I will talk about in general pathology, but just know that integrins, right, so these are like molecules that are on the endothelium. So in these integrins, when they attach to the neutrophils, this is known as adhesion. So obviously if you don't have this adhesion step, if you don't have the first step, the neutrophil will never reach the infectious site, right? And that leads to some of the findings that we see, right? So again, since the neutrophils cannot adhere or attach themselves to the endothelium, there is defective extravasation of neutrophils that leads to impaired chemotaxis and phagocytosis, right? So let's look at the key features and high yield points. So first off, you have to know that there's delayed separation of umbilical cord. This is one of the most high yield findings that I've seen, right? So delayed separation of umbilical cord. Next, you have absent pus formation, right? So it makes sense that if your neutrophils cannot get to the site of infection or the tissue which is infected, it makes sense then that you will have no pus formation, because what is pus? Pus is basically dead neutrophils. So if you don't even have neutrophils, how will you develop pus, right? Again, you will also have leukocytosis, but this is kind of like a false leukocytosis. So if you look at their neutrophil counts or their their neutrophil levels, they'll be very high, but it's not because of the infection. I mean, it is because of the infection, but it is more of the fact that since the neutrophils cannot migrate into the tissue, they stay more in the blood, and that's why you see a higher neutrophil count, right? And again, there will be recurrent bacterial infections of especially of the skin and mucosa. Next, we have Chidiac-Higashi syndrome. I hope I'm pronouncing that right. So this is going to be an autosomal recessive defect in the LIST gene. So LIST is basically lysosomal storage trafficking, right? So this LIST gene is responsible for lysosomal trafficking, right? And I'll explain this in a second. So this impaired lysosomal trafficking leads to a microtubule dysfunction that leads to impaired phagosome and lysosome fusion. Now let me explain what I'm trying to say. Let's say this is a neutrophil and it phagocytoses one of the microbes, right? So now it's inside and it forms this vacuole around it that is known as a phagosome, right? Now you also have another vacuole that is known as a lysosome. The lysosome contains all your hydrolytic enzymes to basically break down the microbe itself, and this requires fusion. So when both of these fuse, then the lysosomal enzymes can be released, and that can lead to formation of what is known as a phagolysosome, right? Now this process of fusion between the phagosome and the lysosome, this requires the microtubules, right? And those microtubules require lysosomal trafficking gene. So again, so this means that when you have a defect in the LIST gene, right, in the trafficking gene, you have a microtubule dysfunction, and that leads to impaired fusion of them. Now this leads to some consequences, right? The first thing that you have to know is that this microtubule dysfunction is not only restricted to the phagosome and the lysosome fusion, it also affects other processes. It prevents the intracellular transport, and let me just explain. So the first symptom that you have to know is partial albinism. So let's say this is your skin, right? This is your skin and it contains all your keratinocytes. And below your keratinocytes, you have these cells which are known as melanocytes. Now, the melanocytes make what are known as melanosomes, right? So it creates these melanosomes, which are again vacuoles that contain melanin. Now, this melanin is transported from the melanocytes to the skin or to the keratinocytes, and this is responsible for the color of your skin. Now, what happens in Chidiac-Higashi, because you have this microtubule dysfunction that prevents this transport, the melanin never reaches the skin, and that is why you get partial albinism. And the same concept goes for recurrent bacterial infection. And you also get giant granules. And finally, neurologic abnormalities. Can you take a guess as to why do we see neurologic abnormalities? Okay, the reason is because you know that neurotransmitter release requires the fusion of microtubules in the synapses, right? So if you have a defect in that, then obviously you will not be able to release the neurotransmitter, and that leads to stuff like peripheral neuropathy and neurodegeneration, right? So this is Chidiac-Higashi. Next, I've talked about this, I think, a lot of times, chronic granulomatous disease, or CGD. So it's an X-linked disorder, X-linked defect in NADPH oxidase. NADPH oxidase is responsible for converting O2 into superoxide anion, right? So and then this goes through further processes to make what are known as reactive oxygen species. So these reactive oxygen species are very effective in killing off bacteria, right? Now, obviously, if you don't have NADPH oxidase, then you have impaired reactive oxygen species killing or impaired oxygen dependent killing, right? And that again is not a problem until you are infected with a catalase positive organism. The reason being because if you are not infected with a catalase positive organism, what your body or what your cells can do is that they can use the hydrogen peroxide that is made by the microbe, and they can use it to make their own reactive oxygen species. But in a catalase positive organism who basically metabolizes their own hydrogen peroxide, so you cannot use it, and you will be more susceptible to catalase positive organisms. And I have talked about the examples of catalase positive organisms such as Staph aureus, Pseudomonas, E. coli, Aspergillus, right? All of these. Okay, so what are the clinical features that you will see? Obviously, recurrent catalase positive infections. You will also see granuloma formation. Why? Because since it's a chronic granulomatous disease, I mean, it's in the name and it's a chronic infection, so you will also see the formation of granulomas. And what will the labs show? So the nitro blue tetrazolium test will be abnormal, and NBT test is basically responsible for detecting the presence of NADPH oxidase. So obviously it will fail to turn blue. But the important test that is more common these days, that is known as dihydrorhodamine test. So this will again be abnormal, and this will present with low green fluorescence. Next is myeloperoxidase deficiency. Myeloperoxidase is responsible for converting hydrogen peroxide into hypochlorous acid, right? And this is basically a halide radical, and this is the most effective weapon that we have against microbes, and it really destroys them, right? Again, so if you have a deficiency of MPO, then obviously you will not be able to form your hypochlorous acid, and you are more susceptible to candida infections. That's the only thing that you have to know. And obviously your nitroblue tetrazolium test and your dihydrorhodamine test will be normal because your NADPH oxidase is still functional. Next, our early complement deficiencies. So early complements are going to be from C1 to C4. So these contain your C1, C3, right? And most importantly, C3. So you know that your C3, especially C3b, is responsible for immune complex clearance, right? I've talked about this before. So if you have low C3b, that means your immune complexes will not be cleared. They will accumulate in tissues, and that can cause what kind of hypersensitivity? Exactly, type 3. And do you remember the most important type 3 hypersensitivity reaction that I talked about? Exactly, SLE. So you have an increased risk of developing SLE. Next, obviously, since you don't have C3b, C3b is a great opsonization protein, right? So obviously if you don't have an opsonizer, so obviously you will be more prone to recurrent severe bacterial infections, especially by encapsulated bacteria, because encapsulated bacteria are removed from the body via opsonization, especially by antibodies and complement proteins, especially C3b. Next are your terminal complement deficiencies. So terminal complement are going to be from C5 to C9, and you know that these form what is known as your MAC. So membrane attack complex, right? And I've told you what it does. It punches out holes onto the membranes, and it causes the bursting of the microbe. So if you don't have C5 to C9 terminal complements, right, you won't have your MAC formation, and MAC formation is important for Neisseria species. So Neisseria, gonorrhea, and meningitis. Okay, so you will have recurrent Neisseria infections. And lastly, we have severe congenital neutropenia. This is also known as Costman syndrome. What all you have to know is that there is an arrest of neutrophil maturation, basically meaning that you will have a very low absolute neutrophil count. So all you have to do in this to diagnose this is that first of all, look at the neutrophil count. If it is very low, that means that this is just severe congenital neutropenia, right? So you have recurrent bacterial infections, because you know neutrophils are really important for bacterial infections. You can develop impetigo. Impetigo is honey-colored crust on the skin, and this is usually due to Staph aureus and also Strep pyogenes. Otitis media, right? So inflammation of the middle ear, and pneumonia. and often they are infected with Staph aureus or streptococcal infections, right? And the labs will show severe neutropenia, obviously, so your neutrophil count will be very low, but your overall leukocyte count will be normal. So other like lymphocytes, macrophages, eosinophils, basophils, and whatever is there, those will be normal. It's just that the neutrophils are so low that you cannot fight off infections. So how will it present? It will present with early onset severe neutropenia with recurrent bacterial infections. And sorry for the spelling mistake. So bacterial infections in an infant. So this is what impetigo looks like. So you can see that these are like honey colored crusting of the skin. And this is mostly caused by Staph aureus, but also can be caused by strep pyogenes, right?